And our second presenter is going to speak on community empowerment through healthcare, the critical role of Lebialem diaspora. For those of you who do not know, our next speaker is Dr. Edumd Folefac. Dr. Edumd Folefac is a professor of healthcare in the United States. He teaches at Ohio State University School of Medicine. He himself is a practicing medical doctor, a professor, and his area of specialization is cancer. He's an oncologist, by profession, and Dr. Edumd is one of the sharpest minds that the Bawa community has here in the United States. And we will be listening to Professor Edumd Folefac. Dr. Edumd, if you are listening to me, we are ready to listen to you. Over to you, and unmute your microphone, and you have the floor.
All right. Thank you, Mr. Moderator. I think it always does one a lot of good to know the moderator, because sometimes they give you too many more accolades than you actually deserve. As he was talking, I was looking around me to find out if I have a twin brother somewhere, but who knows where my father would have gone. That said, ladies and gentlemen, my job here is to really talk to you about healthcare. And I would, and just not the kind of healthcare in the way you think you know it, but I want to bring your attention to healthcare the way you probably haven't thought about. And part of the reason why I got inspired to do this is actually after a lot of the huge support that Legda USA received to help two of our ailing brothers and sisters back home. One, Shanella, Miss Shanella, who had a cancer, was blinded from death and had her arm amputated, her leg amputated. And actually, thanks to the generosity of Father Peters in Douala, her situation was brought to our attention. Unfortunately, after all we did, she passed, but passed in dignity, knowing that she had a family here, was able to talk to her. She died in dignity after following a lot of the help that you gave us. The other one is Mr. Vincent, who is currently still receiving treatment. You people might have seen this guy with a huge mass on his neck. It's almost incredible what our people can support. That somebody like that was carrying that thing on his neck for a long time. And ultimately, I think now, if we had a chance to be able to show you the pictures, which I would defer that to the CEO, you would see that this guy is actually undergoing treatment and responding really well beyond our widest imagination. So these things started talking to me about what really it is possible that our people really can help. Because all the while, I think many of you listening to me on this forum would have actually, there are quite a few of you here who would have reached out to me to help out either in Cameroon or to help out here in the United States. But actually the question is, why do you have to only do it if you know me? Why not actually expand that opportunity to everybody else? And why not bring in our healthcare experts here? As you can see from the conception of my thought, I'm going to ask you what is health, then talk about health care and not sick care. What I'm talking to you here is not healthcare, is healthcare. And then talk to you about the fact that healthcare is equals to social justice, it's a human right and an economic empowerment, too. And then looking at the Lebialem before the war, that has devastated our country. The problem is, if I ask you, what were the problems of Lebialem? Many of you will talk about, corruption, embezzlement, lack of unity and everything else in between. But I will tell you that that is actually, those you are talking about the causes and not about the effects and not the cause. The root cause of Lebialem problem and many problems, conflicts in Africa is just that, instead of having what the social contractarian in philosophy would call the general will, which is actually our social contract actually predicated on the general will, which is the interest of the masses. It's come to more be the general's will. And whether these generals are in uniform or politicians pretend, such that the resources of everybody, the power structure is actually tilted to the people who govern and not really to the interests of the people. And I'm going to tell you I'm going to show you how that actually impacts your healthcare. And I will make an argument here that healthcare can be that graphene that is capable of reuniting us and then reinvigorating post-conflict Lebialem towards attaining its full creed and potentials. And by that, I want to mean that, it would be a wasted 4 years or 5 years or however long this war would end, if after this war, we go back to rebuilding and that our rebuilding structure actually, it's predicated on the same kinds of, faulty foundation that has led us to be at war in the first place. There is no one of you who is sitting here who knows the politics of Lebialem who would have thought that Lebialem was a healthy a healthy community before the war. And that's probably explains why the consequences of this war in Lebialem has been that's devastating. So I want to say, when I talk to you, when we talk healthcare, we're looking at key measures of health. And I'll ask you, what is health? The WHO would define health as the state of physical, psychological, and social well-being, not just the absence of disease and infirmity. So Madame Nonjang talked about a couple of issues within the BLM, the anger, the fact that people are just not truly able to even provide. So if you don't have a job, and you cannot provide for your family, you really cannot be healthy. If you actually are in a place where you are discriminated against for people who beat their wives and there is social violence and all of that stuff, no, you cannot be healthy. If you don't have nutrition, you cannot be healthy. A lot of mental disease in our community is actually, people don't realize mental health as a big health need. And in medicine now, we're beginning to learn about what we would call allostatic load, which is like the sum total of all these pressures of life, which actually would make it that the poor people always end up on the short end of the stick. They always end up living shorter than the richer people. Those that are discriminated or those that are deprived end up living shorter. And so look at this life expectancy in London, but you can replicate this elsewhere. I mean, in England, you can replicate this elsewhere. If you see here, the most deprived on this, and then the least to the least deprived, from this scale, you realize that the most deprived would have a life expectancy of about 70-something years, while the least deprived have a life expectancy of about 80-something years, about a 10-year gap in between. So that tells you that poverty itself is a disease. Deprivation is a disease and capable of shortening your life. The graph below is even starker. That's what we call, disability-free life year. That is, life is not probably just the number of years you put in, but it's about, how fully do you live that life? So if you're poor, if you have all those deprivation, no nutrition, no education, and all of these other things, that life, those quality life years are even far fewer. And here you can see the life expectancy in the United States. And I'm going to tell you why I'm showing you this graph. If you look at other countries, what that we call OECDs, and these are the so-called developed countries. If you look at the life expectancy in those countries and the life expectancy in the United States, the life expectancy in those other countries is higher than in the United States. And just keep this graph in mind when I come back to tell you why. Yet the United States spend much more, probably twice or 3 times on average on healthcare, more than all these other countries. Next slide, please. So here is the life expectancy of people in the United States from the 1900s to 1919. If you look here in the early 1900s, the life expectancy in the United States, and I look at it, like the Black, white, Hispanics, and Asians on this curve. One of the things that would come, and very early on in the early century, early 1900s, the life expectancy in the United States was about roughly about 40 years. For Black people, it was 30-something years. Now, fast forward to the year 2019, the life expectancy for an average white person is about 80 years or 82 years. And then for a Black man, is about 76 years. But there is something about 72 years, So there is a constant there. You see that whether it was in the 1900s or now, the life expectancy for Blacks is actually shorter than Blacks. That means Black lives on average shorter than whites. But one of the things that you can see is that as the economy has improved, conditions of health and all of other things have improved, our lives have actually generally, we've been living longer, but that benefit has not been spread equally to everybody. Next slide, please. And I would just look at the inequality, wealth inequality. And if we look at here in the United States, the wealth inequality is much higher than any other country on this graph. So you can see that one of the critical determinants of health is actually the wealth inequality in the community. The higher the inequality, the poorer the health of the community. Next slide, please. And just infant mortality rate here, just want to point out to you that on average, a Black infant is 3 times or 2 to 3 times more likely to die than a white infant in the United States. Next, please. And here is actually looking at childhood poverty. Of course, in childhood poverty, in America, amongst the white folks, it's about 10%. Amongst the Black folks, it's about 37%, meaning that our Black folks, kids actually have, they're 3 times more likely to be poor, which actually translate to shorter life, which translate, and of course, poorer health. And we're going to get into a little bit more of that. Next slides, please. And this is, just again, tragically, please. And here is actually looking at childhood poverty. Of course, in childhood poverty, in America, amongst the white folks, it's about 10%. Amongst the Black folks, it's about 37%, meaning that our Black folks, kids actually have, they're 3 times more likely to be poor, which actually translate to shorter life, which translate, and of course, poorer health. And we're going to get into a little bit more of that. Next slides, please. And this is, just again, tragically, the United States is the richest country in the world. But look at other countries like Denmark, Sweden, and then compare it to the United States, which is right here as I'm pointing with this slide, to see that the level of childhood poverty in the United States is sometimes also about 2 to 3 times the level of childhood poverty in those other countries. And these numbers are usually mostly driven by the childhood poverty in the Black and brown community rather than in the white community. Next slide, please. And in terms of maternal mortality, that is the likelihood that somebody is going to die from giving birth to a child. A woman is going to die giving birth to a child. Again, those are the numbers. You can see that this is about 3 times higher in the Black community compared to the white community. Next, please. And that pregnancy-related complication, if you break it down by race, is actually is way worse for Black people, especially when they get up to the ages of 40, which is right here. You can see the real big spread. So these are some of the issues that is causing our life expectancy as Black people in this community to really be as poor as it is. And we'll get into some of the reasons why. Next, please. And then, as we've just been talking, I think we cannot finish this data without talking about COVID. This is the rate of COVID deaths in this country. If you compare the rates of the white folks to the Black folks who have died of COVID, in some cases the rates are like 3 times as high. In some age groups, it's even much higher than that. It's actually even about 6 or 7 times as high. So that you can find communities like in Chicago or even Atlanta, Detroit, where Black people live, even though they will constitute a significant minority of the general population. But when it comes to the number of COVID deaths, the majority of those people who died or ended up in the hospital intubated and sick were actually Black people. Next slide. So the question is why? So, and I want to make an argument and tell you that it is your zip code rather than your genetic code that determines how healthy and how long how healthy you are and how healthy and how long you will live. And, you know, and to take this, I would just tell you, look at the state of Hawaii. The life expectancy there is 82 years. In West Virginia, much more deprived community, is less than, it's about, you know, 8 years less. And staggering statistics in Baltimore, and just within one city, Hampton Park or Hampton or Drew Park is a place where it is actually inhabited mostly by Black people. And then Roland Park is a state that, I mean, it's a part of the city that is inhabited by white people. And these are places that are separated by just a few miles. The life expectancy in Hampton Park is 63 years old. I mean, it's 63 years. And then in Roland Park, where the white people or the affluent county, it is about 83 years old, a 20 years difference. And in Texas, if you look at Fort Worth, Texas, the life expectancy there is 66 years old. Meanwhile, in Hoto, which is actually where most of the rich people would live and mostly white, the life expectancy is 97 years old. So these people don't have different genes. They don't have different, and the only thing here is really because of the condition in which they are born and they grow, the school, and then they live and they eventually die. And that's what we will call the social determinants of health. Next slide, please. And I want to show you exactly why that actually is the case. If you look at this, when I talk to you and I say health, and I think that most of you will be thinking about a doctor, a nurse, a social worker, pharmacist, and things like that, and then a hospital. Yeah, you are right. But look at where health services in this thing that we call the iceberg of healthcare. Look at all these other things that are underneath here that determine how healthy you get. You need, if we can prevent you from getting sick, then you don't even need a hospital, or you don't need people like me in the first place. But how do we prevent you from getting sick? We prevent you from getting sick by changing your values, by changing your assumptions around life, by changing your belief, by looking at making sure that your childhood development, you are healthy during your childhood development, by making sure that you are educated, you are well educated, you have an income that would allow you to have a living, to live a life, you know, that is much more fulfilling. You are employed, and so that, and we now know that if you have any of these pressures of life, that they affect right down to your genetic, to your immune system. And so that it is not for nothing that sometimes you hear somebody who has been previously healthy, or even in Cameroon, for instance, you see people who work, eventually get retired without any planning. They go to the social welfare and they cannot have their salaries or maybe their retirement allowances. The next 2, 3 years or 5 years, they are dead. And then people think, oh, maybe it's witchcraft and stuff like that. Don't blame it on witchcraft, blame it on the system, on the system that we call the social determinants of healthcare. Next, please. So I didn't want to make your afternoon so bleak. The question that if we are here in the United States, if you see why the Black people actually have a poorer health and poorer life expectancy here in the United States, it is not because of the gene, it is because of the discrimination ranging from the food, the education, the guns in the community because of social deprivation, and you know, the lack of exercise program, or activities, and then and all these other things, not just the lack of hospitals and qualified doctors within those areas, even though it would help. Look at obesity in America. I would make an argument. You see, obesity in America is a disease of poverty. So what can we as a Lebialem people do to help our people right here in the United States, do people who don't have health insurance, empower you with the knowledge, even those people who have health insurance, empower you with the knowledge of the things that actually, you know, affect your health much more than just coming to me or to the doctors, and what is it that we can really do, and what can we do for the people back at home? COVID has given us a lesson that we could leverage a lot of our expertise here with the expertise at home, link up with what we, and create a platform, link up with what we now call telemedicine. And I will walk you through that in order to be able to create a better healthcare system for our people, and therefore and empower our people economically. A sick parent, if you are sick, you can't take care of your kids. If you can't take care of your kids, they can't go to school. Those kids are destined to fail in the future. And if you are sick and then you can't take care of yourself, there is no way that you could have joined us on this forum anyway. Good, thanks. Next slide, please. So in Lebialem, before the crisis, these are the healthcare facilities in Lebialem compared to the rest of the places in. You can see it's almost like healthcare facilities in the southern Cameroons, and if you can see that the Lebialem itself, Wabane and Fontem here that I show on this slide, it was almost like it was an afterthought. These are the few small, tiny number of healthcare facilities, and they were very ill-equipped to start up with. And so not only did we not even have the healthcare infrastructure or the healthcare facilities, they were very ill-equipped. Next. And that's just a list of all the healthcare facilities that we have, and many of these were only in name. If you see here on this column here, some of them actually are indicated constructed. Those that are functional. The zero means that it was never constructed and it was not functional. And we would all know that in many of these places, some of these healthcare facilities that are designated, like a lot of the schools in our areas, were just in name only. Next, please. Just go past this one. This is just another version. So I've started out to begin to think about when we finish the war, when the war ends, what next? So I turned out to work with some 5 folks in technology to begin to create a health map in Ambazonia, to really look to see where are the healthcare facilities in Ambazonia and currently. And my hope here is to eventually get to a point where we can be able to get the hospitals and calculate the distances where the hospitals are or the healthcare facilities would be. So at some point, when this war is over, we can build ourselves a healthcare system rather than a sick care system that is currently in existence. Next, please. That's just a little bit, the slide is a little bit blurred, but this is actually was just a trying to zoom in to actually show you a little bit more about the healthcare facilities in Lebialem. Next, please. And so what is our mission here as the Lebialem people? We want to make Lebialem, we think that health is wealth and freedom, and we intend to make every Lebialem person here healthy and free through provision of healthcare. And what the things that we want to set up to do would be to make sure that we promote a healthy lifestyle, nutrition, exercise, clean water, better air quality, education, promotion, and all the other things that we talked about which affect our health. And ultimately, when our people are born back home, we need to be able to ensure that all of them get the preventative services that they need. Disease prevention, does everybody have their vaccine? We can get some school nurses to when we get when the war ends, we get school nurses who can go to different schools, during once or twice a week or however often we think it's necessary to kind of diagnose these kids with some of the different minor illnesses such as parasitic infections and all whatnot, treat them before they get to a point where the kids would have to absent school. Then we would have to screen, do screening programs for early intervention. One of the biggest killers in our community is hypertension. We're beginning to have a little bit more diabetes as we adopt westernized diet and other problems that are a little bit more chronic in nature. So you definitely can screen out all of these things and treat them before they get, before they fester and become more more expensive to treat and probably in many cases become futile. So, and we would actually want also to create a system that can provide our people not just screening and preventing, but also the best healthcare system, the best healthcare at the most affordable cost that they can afford. And here comes the concept of a health care insurance scheme back at home to enroll all our people to pay in a certain premium, and which we can then use that money to make sure that the few that are sick get the healthcare system the healthcare that they need. Those that are not sick, that same pool of people that are in that system, you can then design the healthcare literature that you need, the health education that you need. And ultimately, one of the critical things with this is you will teach them how to be healthy with their nutrition, exercise, and all things. But one of the critical things that we'll need is we'll also empower them how to advocate for themselves and how to ask, how to, make sure that they hold the elected representative to account, how to make sure that somebody who takes a contract to build, whether it is a school for their kid or a hospital, actually is also able to, deliver on that promise. So if you are able to pull in a Lebialem group cohort of about 5,000 people in that healthcare insurance, that's a very powerful group for you to begin to be able to do all the work, education that is needed in order to empower them. And like I said, we will leverage telemedicine to make sure that we can help our people here in the United States and then those back home in the country. Next slide, please. And the first thing that we need to do in order to do that is to create a database of Lebialem health professionals who are based here who are based in Cameroon, i.e. we look at doctors, their areas of specialization, pharmacy, lab technicians, and all of that, put them in one category. Next, please. We also create the professionals here in the United States, database of professionals here in the United States, and bring them under one pool. Again, then we'll be able to, next slide, please. I'll then show you a diagram that would link up like this. Next, just go back to next slide. Time for the interest of time. Next slide. Okay. I'm not sure and our goal is that, just go to the next slide. I want to show so that, yes. So this is the critical schematic program. So imagine that you are in Lebialem and you are sick. These are the people, or you have a healthcare question. There is this healthcare professional pool here in Cameroon where you can call into that database and then present your problem. The healthcare professionals within that group would call you back, and then if they can be able to sort out that problem, fine. If they cannot, they can direct you to a hospital, and or you go to the hospital where you are. They know that you are in that hospital. If you're in that hospital and you have a problem, one of the things in Cameroon is actually finding out where the experts are. So these healthcare professionals in Cameroon will know where the experts are to direct you to the particular expert that you really need. And then they can follow up to make sure that you actually get the appropriate care and follow up, and also your aftercare. And now with the healthcare professionals in Cameroon, we have another database here, which is where they on the platform where when they take out in that information, some of the issues that they may encounter, they may not be able to, they may not know what to deal with it. They put that information here in this database. We here in America or in diaspora take that information here that they've put here and then address that particular issue and give them that information in that database, which we then take and then address the concerns of the people back home. So in the United States, we'll create a different, here is the healthcare professional pool. The people in the United States, if you are going to your doctor, if you don't have health insurance, if you have a health care question, you can put it in that platform, that database or that platform. We, the healthcare professionals, would then pick that information, look, and then reach out to you and address your concerns, and thereby empowering you and making sure that you have the best care that there is that you can possibly have here in the United States. Next. And so it turns out that the Catholic Church in Cameroon, in the Southwest and Northwest in the Bamenda Archdiocese, actually have a health insurance scheme called the PEPFAR program. As we were looking, so I reached out to Father Lois, who is working on it, and I would present this information to the leadership of the board to really show them that we can be able to pay, and the premium actually for that particular program is just about $4,000 a year. With that, people are able to at least get some health check, antenatal care, have some benefits. You can be admitted to the hospital at least, I think, about 3 times a week, and I will share that information with the leadership. I have been on this on the phone with Father Lois, along with Dr. Rocky Hillary. We've been trying to figure out how good and how sustainable is this program. They're having some issues with the program, basically based on the fact that the program was initially supported by the Bishops' Conference from Germany, and they had given them a time frame within which to enroll as many people to be able to make the program sustainable. But the war actually threw a monkey wrench into the plan, and they've not been able to enroll as many people as they would have loved to. But I think we here in the United States, as a diaspora, we really can help with this insurance program and pay some of the premiums for the people who may not be able to pay. And in addition, we can then ask the people from there, we can actually task them to pay back by doing community service to the people. So if we are able to how do we not think that this could be the most impactful thing, one of the most impactful things that we could do for our people, to sit there knowing that with 4,000, you can actually change the life of somebody in Cameroon. And those of us that are in healthcare, and I'm reaching out to all of us that are in healthcare, and I think we are willing to offer our time, free, and do everything that there is to do. We're just asking you to please consider funding some of these projects, and we can work with you to make sure that we do the best that we can do for our people by empowering them, making them healthy, and then doing all the other benefits which would enable them to eventually get all the other benefits that we're talking about. So the healthcare campaign through the health professionals back at home would be, we can do them at the market square, you can do them everywhere that there is to do. And again, we can design all of these programs and then work with the healthcare team back at home, and the healthcare professionals back at home, and wherever necessary, use telemedicine, which I've been doing now through this COVID, to do a lot of healthcare delivery in Africa, in my area of expertise, consulting across Africa and across the world. Next program, please. Next slide, please. So, people, one of the things I would say, this may come down, this is just showing you an academic performance by nutritional status of children. And I know why I'm showing you this slide, so that a healthy child is a much more intelligent child, whether it was the performance in math, in language, or in GPA generally. You see that the least, the most malnourished couldn't really even compete with those that were the best, or were the best nourished kids, especially at early childhood. Your brain needs, so your brain would need an adequate nutrition in order to be able to develop maximally, and a hungry kid cannot learn. So it makes this data, I think every mom or every parent would tell you that this actually is a data that they would have been expecting. And every school student, which I think many of us have gone through school, and then we knew, when we're hungry, there was no way we could have actually learned. So one of the things I'm thinking is, let's think that 10 years from now, 20, whether it's 15 years from now, we'll have a Lebialem school meal project, whereby my goal is to, at some point in the future, have a situation where we can, get, whether we're raising poultry at school or however we want to do it, so that every little, especially those in the elementary school, can have at least an egg a day. And so they can be able to get the nourishment, an egg and a glass of milk a day. We can just figure out some better ways of being able to utilize the land that we have back home. How do we make sure that we get all these things and we can have them be able to empower the community to grow them, empower the community to feed these kids in a better way that would allow the kids, our kids, to be, the next generation to be much smarter and achieve greater heights than we all have been able to do now. Next slide, please. I'm almost done. So I think what I've presented to you may sound daunting, but one of my idol, whom you people will know here, this is Archbishop Desmond Tutu. My teacher, sometimes in medical school, he would give us too much work, and then we'll ask him, we'll be shouting, and he would say, how do you eat an elephant? And I went looking to see how you can eat an elephant and stumble on what Desmond Tutu said, that there is only one way to eat an elephant, and that is take a bite at a time. So as daunting as some of these things that I'm telling you today may be, or the ones that the Madame Nonjang has talked about may be, or the other people, the other presenters, let's remember that we can eat the elephant, but we need to just take one bite at a time. And I want us as a 99, they call us 99, which means we must find 99 ways of doing something, not 99 reasons for not being able to, for not doing it. Next slide, please. And and if you're asking me, what are you going to gain from this? Then read this quote from Martin Luther King. I believe that unarmed truth and unconditional love will have the final word in reality. This is why right temporarily defeated is stronger than evil triumphant. What I'm telling you is, if we try right now, and even if we are able to not, the trying, giving these people, don't only think about your own family, think about other people that cannot afford. As we ask you to support many of these projects, especially this healthcare initiative, because at the end, it is not just the unconditional love here, is actually thinking beyond your immediate family. And I think the last slide would be my final slide. And if you look at this chain, as strong as this chain is, that is the weakest link. So what I'm trying to tell you people here is that the strength of the Lebialem community is not dependent on those people, on the smartest amongst us, or the most fortunate amongst us, or the people who are the most who have the most privilege amongst us. But it is determined on, it's actually our strength, the strength of the Lebialem community would be dictated by the weakest amongst us. So if we have most of our people in need and we cannot help them, guys, they're going to be like this weak link on this chain. So I really thank you people so much for listening. I hope that you would, by now, you start thinking more about a healthcare in a different way completely, and thinking about healthcare, especially in the context of the BLM, on how we can, use something that affects everybody, and then use it and turn it in a way that we can use it to empower our people and help our people grow to be the generation of the future. Thank you.